Just by way of introduction, there's probably a 13-year difference in life expectancy between an African-American male who doesn't complete high school and a white male who's college educated in the United States.
If you have the access to the best, most high qualified doctor, but you're returning to a community that is fundamentally unhealthy, whether that's because of the air that you breathe or the condition of the housing in which you live, or your ability to access healthy foods, or a place that has been talked about in previous panelists where it's over-policed and there's fear, right? So there's trauma that's happening in these communities, that the reality is that we cannot anticipate that we can have health just by dealing with it in a doctor's office. And in that recognition of place as a part of how we discuss disparities, it's also an intersection not just with place, but also around race, class, and history. The reality is that community conditions that we're talking about are inherently tied to the distribution of power and the allocation of resources in those communities. You cannot separate those things.
People in the community were meeting already to talk about the issues, particularly as related to health issues, particularly for South LA, cardiovascular disease and diabetes. And so when the funding came, they already had a collaboration that had some traction. Fast forward to 2012, Community Transformation Grants, another CDC-funded project. Basically, we were able to take the lessons learned in that first project and share them across the board with other organizations in South LA. But it really was this idea of developing a learning community. And our challenge as the evaluation team was to find ways to document that expertise in ways that were meaningful, to tell the story that the community wanted to tell, and then this whole idea of planning. How do you change community plans and what happens on the ground in such a way that no matter who comes in to live in that neighborhood, they will be impacted by the changes that have been recommended by the community organizations?
I think the central problem we're really dealing with, the big issue we're confronting, is how much can we actually eliminate health disparities without equalizing income. Health behaviors is 30% of it, clinical care is about 20% of it, social and economic factors about 40% of it, and physical environment about 10%. We have to consider education and income across the life course as being so seriously structuring life chances and health chances in American society. You see that in South LA, about 40% of the population, slightly more than 40%, do not have a high school education, as compared to all the other areas of LA, which you can see is vastly different. Look at West LA, 95%.
Here in LA, displacement impacts are certainly a huge challenge. You see issues around proximity to jobs, quality housing, household financial well-being, access to quality education. These are sort of the primary effects that relate to the impacts on health. When you look at the built environment and how decisions are made, in the past, big decisions around infrastructure of where a freeway goes or where our transit goes, in many cases it would completely bisect communities. In many ways it would spatially isolate communities. And so these public decisions, public-private decisions, really need to involve community and community voice as one of the processes to mitigate impacts of health disparities in place.
We have to take a step back and really think about what are the comprehensive confluence of factors that are actually making it certain folks more vulnerable, other folks less vulnerable, and have an honest conversation about how we're sort of distributing those resources to ensure that everyone has access to be as healthy as they can be.